السلام عليكم طلبتنا الأعزاء. I will continue with the left part of the small and large bowel pathology, including the left part is regarding the idiopathic inflammatory bowel disease. We will study Crohn's disease and ulcerative colitis together because of some shared properties between these two gastrointestinal disorder. Both of them are chronic. Both of them have relapsing attacks, relapse and remission. That is a period of relief and active inflammation. And both of them are of unknown etiology, so they are called idiopathic. Both of them have systemic manifestations or systemic inflammatory what are called extraintestinal inflammatory manifestations like polyarthritis, erythema multiforme, pyoderma gangrenosum, uveitis, and so on. Inflammatory bowel disease, again, there is a steady state or continuous state of inflammation between luminal factors and host defense. Genetic predisposition is implicated in this disorder, including HLA, B12, B27, and they have tenfold increased risk in first degree relative, so there is increased susceptibility in genetically predisposed people and family history of these diseases and other autoimmune diseases. So in general, as we say, autoimmune disease or immune reactive diseases comes in clusters with positive family history. Abnormal host immunoreactivity, including impaired function of antigen-presenting cells in the bowel, abnormal elaboration of inflammatory cytokine from inflammatory cells, from epithelial cells, and abnormal function of the natural killer cells with induction or production of anti-epithelial antibodies. Infectious causes like viruses, chlamydia, and mycobacteria can elicit or trigger this autoimmune or abnormal immune reactivity. And repeated attacks of inflammation producing inflammatory product that will result in tissue injury. That is continuous, long-standing on many years and with associated relapse and remission. There is also combined effects of alteration in host interaction with the intestinal microbiota. So change in the normal intestinal flora, bacterial flora, and intestinal epithelial cell dysfunction or dysregulation or abnormal activation, and secretion of cytokines, aberrant mucosal immune responses, and altered composition of the gut microbiome, change in the normal flora of the gut. To start with, Crohn's disease, or called regional ileitis, because of commonest location of involvement is the terminal ileum. So it is called Crohn's disease, regional ileitis or enteritis, and granulomatous colitis because of presence of non-caseating granuloma within the wall in 50% of the affected people. Characteristically, the inflammation is transmural. Transmural, that is, all the four layers of the bowel are involved by the inflammatory process and can start or can affect any part. Crohn's disease can affect any part of the gastrointestinal tract from the mouth to the anus at any point. Whereas it is but primarily involving the small and large intestine. In 40% of the cases, it affects the small intestine alone, and 30% small and large intestine, and 30% the colon alone, and may involve the stomach, duodenum, esophagus, and even the mouth. The mucosa shows linear ulceration and fistula. Ulceration, linear ulceration, and fistula are features of Crohn's disease. Fistula and fissuring. Linear ulceration called fissuring, and fistula formation, that is abnormal tract between two epithelial surface with the bladder, with the other organ, another bowel loop, and the involvement is segmental. Segmental means there is involved bowel segment, followed by uninvolved bowel segment. So normal and abnormal or affected bowel segment are alternating in the gross finding. So it is called the skip lesion. Skip lesion is a feature of Crohn's disease rather than ulcerative colitis. Segmental involvement or skip lesion. So in X-ray, this sign is called string sign. When the dye passes through a narrow segment and dilated segment, alternating dilatation and narrowing. Serosal creeping fat due to fibrosis, serosal fibrosis, and kinking of the fat on the serosal surface. It is also a feature of Crohn's disease. Again, it is called regional ileitis because most commonly involving the terminal ileum, and also called granulomatous colitis due to presence of non-caseating granuloma in 50% of the patients. Again, the wall is thickened wall because of transmural involvement, and it is rubbery. The lumen is narrowing of the lumen, string sign on X-ray. Sharp demarcation of the diseased bowel segment from the adjacent uninvolved bowel wall, that is the skip lesion. Sharp demarcation between involved and uninvolved bowel wall segments. Cobblestone appearance due to lymphoid tissue hyperplasia or follicular hyperplasia, and this appearance will be seen on the mucosal surface. Cobblestone appearance. Narrow fissures, fistula, and sinus tract formation. All of these are gross features of Crohn's disease. Fissuring, fistula, and sinus tract formation. This is a typical this is a colectomy specimen of patient with Crohn's disease. It is typically, the skip lesion is seen here, uninvolved segment and this involved one. So there is sharp demarcation between involved segment, ulcerations, narrowing of the lumen, cobblestone lining mucosa, and the uninvolved or essentially normal segment, bowel segment, skip lesion in Crohn's disease. Here also there is involved segment, so the black arrows showed point toward uninvolved segments, and the green one point to the uninvolved segment. Cobblestone appearance, typically is the pattern of mucosa or the appearance of the mucosa in Crohn's disease. Bulging of the mucosa due to submucosal lymphoid tissue hyperplasia and thickening of the wall. Fissuring, this is the fissure with bleeding in the submucosa. Ulcerations, multiple ulcerations and fissuring that are elongated ulcerations. Can be deep and deep to the muscular wall and can be complicated by fistula formation. Hyperemia also seen, narrowing of the lumen. Cobblestone appearance will result in narrowing of the lumen also. Diffused cobblestone mucosa or cobblestone pattern in the lining epithelium due to mucosal hyperplasia and transmural lymphoid tissue hyperplasia and transmural inflammation. Thickening of the wall is severely thickened. Ulceration and bleeding are seen at the remnant of the mucosa in between. Ulceration, fissuring, bleeding, edema. With this thickening will result in severe narrowing of the lumen of the bowel. Pyoderma gangrenosum. Pyoderma gangrenosum is a cutaneous lesion or skin involvement in patient with Crohn's disease. Pyoderma gangrenosum affecting the leg here. So this is called extraintestinal manifestation or extraintestinal inflammatory manifestation in inflammatory bowel disease. Microscopically, inflammation is transmural again. There is mucosal inflammation, always neutrophil indicate activity, and the crypt abscess. The crypt abscess means presence of neutrophils and necrotic debris within the crypt of Lieberkahn or within the lumen of the gland, colonic glands. Crypt distortion and atrophic changes. Also, there is characteristic non-caseating granuloma seen in half of the cases. This is the normal ileal or small intestinal villi, tall, elongated, parallel, finger-like villi. You identify the elongated villi and the underlying crypts to be compared with this is a picture for colonic thickened transmural inflammation in Crohn's disease. The inflammation is transmural, started from the mucosa, submucosa, muscular wall, and serosa. And here there is presence of multiple, these rounded structures are granulomatous reactions or granulomas, rounded structures, collection of epithelioid cells. Granuloma are collection of epithelioid cells with giant cell formation in the center. They are non-caseating in contrast to tuberculous granuloma. Again, the inflammation is transmural, started from the mucosa, reaching the serosal surface, and there is intense interstitial or stromal inflammatory infiltration, heavy plasma cells and lymphocyte infiltration. This is called crypt distortion, and crypt atrophy. Crypt atrophy is manifested or seen by the decrease in the number of the crypt or decrease of the number of the glands. So the glands due to chronic ongoing destruction chronic ongoing destruction and loss of the crypts. Goblet cell depletion or goblet cell loss are seen in some glands as a sign of chronic destruction and chronic inflammatory process, and this is the non-caseating granuloma seen within the wall in 50% of the cases. Also, crypt abscess can be seen in some neutrophils, can be collected in the lumen of some glands. Again, this is a granuloma, rounded structure or collection of epithelioid cells with giant cell formation, Langerhans giant cells. Again, transmural inflammation, and here there is clefting within the mucosa can be reached to the muscular coat or can be penetrate through the serosa. This is the colonic fissures or mucosal fissure. Active inflammatory process is indicated by increased mitotic activity and increase in intraepithelial lymphocytes as a sign of chronic inflammation, and also associated interstitial inflammation, and also another sign of regenerative changes, including cellular hyperplastic changes and so on. Even dysplastic changes can be detected after long-standing inflammation, attacks of inflammation. Clinically, the patient is young adult, usually at 15 or up to 30 years old, 35, with diarrhea and abdominal pain, vague abdominal pain, and fever. The symptoms are very vague in Crohn's disease. Complication is fistula formation and bowel obstruction due to thickening of the wall and severe transmural inflammation, occult blood in the stool, that is silent blood loss, and iron deficiency anemia. This is called anemia of chronic diseases due to chronic blood loss. Malabsorption due to lymphoid hyperplasia, due to destruction of the mucosa, decrease in the surface absorptive area, and also transepithelial transport will be affected. Malnutrition due to impaired absorption of nutrients and nutritional deficiency, weight loss, and fistula and stricture. Fistula, stricture, sinuses are also complication of Crohn's disease. Extraintestinal manifestation or extraintestinal inflammatory manifestations seen in both ulcerative and Crohn's disease and ulcerative colitis, including polyarthritis or migratory polyarthritis, ankylosing spondylitis, erythema nodosum, skin manifestation, clubbing of fingers, this is a sign of chronic disease, uveitis, and increased incidence of cancer of small and large bowel. By 5 to 6 folds, there is an increased risk, but the risk of cancer for ulcerative colitis is much more common. Regarding ulcerative colitis, the inflammation here is mainly involving the mucosa of the colon, mainly mucosal and submucosal, with diffuse continuous inflammation that started in the rectum. So the rectum is involved in 100% of the cases, and the disease progresses proximally in a continuous pattern, an ascending pattern starting from the rectum, sigmoid colon, descending colon, transverse colon, and ascending colon. Pancolitis is occur in 20% of the cases. Pancolitis in 20% of the cases. 40 to 50% involving the rectosigmoid. 40% of the cases involving the rectosigmoid. Pseudopolyp formation. Pseudopolyp formation is a feature of ulcerative colitis, that is formation of or remnant of the remaining ulcerative mucosa, the remaining parts or the remaining pieces of the areas of the mucosa is called, will be bulged and called pseudopolyp formation. With chronic disease also there is mucosal atrophy or atrophy of the wall, thinning, severe thinning of the wall of the bowel, severe thinning of the wall of the bowel result in severely atrophic wall of the colon. The serosa is normal essentially, not the inflammation, not reached the serosa. Bloody diarrhea or fresh blood in the stool is a feature of ulcerative colitis related to rupture or distracted blood vessels in the inflamed mucosa and submucosa. And toxic megacolon. Toxic megacolon is a complication of ulcerative colitis. This is related to the destruction of neural plexus within the wall of the colon and resultant dilatation, and can be complicated by severe dilatation and rupture and even septic shock. There is a mnemonic summary for the features of ulcerative colitis, that is the letters of ulcerations. Ulcerations. Ulcers for mucosal ulceration. Large intestine started in the rectum and in ascending pattern, continuous pattern. The large intestine is affected in 100% of the cases. Carcinoma, there is increased risk of carcinoma. Extraintestinal inflammatory manifestations of inflammatory bowel disease, including polyarthritis, ankylosing spondylitis, uveitis, and skin manifestation. Also, the pseudopolyp formation that are remnants of old ulcers, and crypt abscesses, abscess and crypts, a collection of neutrophil within the crypt of Lieberkahn, and toxic megacolon. That is a rare complication of ulcerative colitis with the increased incidence of rupture and septic shock. Inflamed red granular mucosa, and especially at the onset of relapse or active inflammation. Origin at the rectum, originates at the rectum. The rectum is involved in 100% of the cases. And neutrophil invasion, always neutrophil indicate active inflammatory process or active ongoing inflammation. And the repeated attacks of activity will enhance the dysplastic changes and malignancy in the future. And stool is bloody stool or fresh blood in the stool. Microscopically, neutrophils early stage, later stage, and late stage. In the early stage, neutrophils accumulate within the depth of the crypt, of Lieberkern, forming crypt abscesses. Fibrosis causes crypt distortion and mucous cell depletion. Crypt distortion, abnormal shape of the crypt of the gland, distorted shape, and mucous cell depletion or goblet cell loss or goblet cell depletion as a sign of chronic ongoing inflammatory process. Later phase, the mucosa shows ulceration and pseudopolyp formation, and in the late stage or advanced stage, after many years, 10 years and more, the mucosa becomes dysplastic. So it is important to take frequent or to follow up the patient by frequent colonoscopy and biopsy to identify foci of dysplasia, epithelial dysplasia that can carry the focus of invasive cancer within the or colonic adenocarcinoma in these foci. Pancolectomy, this is the ileum, ascending colon, transverse, descending colon, bleeding, edema, and pseudopolyp formation are detected within the lining mucosa. Also erosion of the submucosa and submucosal vessels related to bleeding and ulceration, and fresh blood in rectum, fresh blood in stool. Pseudopolyp, large number of pseudopolyps that are the remnant of unulcerated mucosa. In between these are the ulcerations and exposed submucosa. Here there is erosion of submucosal blood vessel erosion and destruction, which will are responsible for the bleeding or fresh blood in rectum. Erythemanodosum is a skin or cutaneous manifestation of ulcerative colitis that are extra-intestinal inflammatory manifestation. Pancolectomy, another pancolectomy specimen, ascending colon, transverse and descending colon, bleeding, erythema, and severe thinning of the wall is seen. The wall is severely thinned and transformed into a pipe like tube with loss of haustration or loss of haustry of the colon, and due to severe thinning and fibrosis and atrophic changes of the wall. Microscopically, the changes of ulcerative colitis is severe inflammation, ongoing inflammation, active inflammatory process, heavy stromal plasma cells, lymphocytes, and neutrophils. Neutrophils can collect within the crypt, within the lumen of the gland, result or forming crypt abscess. This is the crypt abscess, can be seen in ulcerative and Crohn's disease. Goblet cell loss or goblet cell depletion. Goblet cells will be lost. Only few goblet cells are remaining. Glandular distortion or crypt distortion, distorted shape and architecture or outline of the gland, and crypt atrophy. The stroma here is devoid of crypt or gland, so there is decrease in the number of the crypt, called crypt atrophy. Crypt destruction by ongoing active neutrophilic infiltrate, superficial erosion, and the inflammation is mainly mucosal and submucosal. Crypt abscess, crypt distortion, goblet cell depletion, crypt destruction, and so on. This is the remaining mucosa of pseudopolyp, and here there is the ulcerated mucosa with severe submucosal and submucosal inflammation, heavy intense lymphocytic infiltration and plasma cells in the stroma. This is prominent. It's what we call it crypt distortion, severely distorted shape or outline of the crypt or of the gland. Crypt abscess, here inflammatory cells are seen within the gland. The mucous cells are decreased in number, goblet cell loss, and even dysplastic changes can be seen within the in these lining epithelium undergoes dysplastic changes or ongoing inflammatory changes. This is a picture showed the crypt distortion and destruction here of the crypt, intraluminal neutrophils and necrotic debris, that is crypt abscess, goblet cell loss, and even dysplastic changes are seen here. Dysplastic changes, hyperchromasia and high NC ratio, and regular nuclear membrane, and so on. Increased mitotic activity and severe hyperemia, fibrin deposition, bleeding, vascular congestion within the mucosa. Here another picture showed the dysplastic glands distorted and with goblet cell loss and dysplastic changes, heavy surrounding intervening stromal intense inflammatory infiltration. This is a picture to compare Crohn's, in which there is granuloma seen in non-caseating granuloma with Langerhans giant cells seen within in 50% of the cases, and whereas in pseudopolyp are a feature of ulcerative colitis. Fissure in Crohn's disease, elongated or longitudinal cleft started from the mucosa deep to the muscle coat, or even can penetrate the serosa, forming fistula with fistular tract with another epithelial surface. Some comparison or some finding between Crohn's and ulcerative colitis. Transmural inflammation is mainly in Crohn's disease. Pseudopolyp is in ulcerative colitis. Granuloma is a feature of Crohn's in 50% of cases, and diffuse inflammation is a feature of ulcerative colitis started in the rectum. Skip lesion is for Crohn's disease. Toxic megacolon is a complication, rare complication of ulcerative colitis. Creeping fat is a feature of Crohn's disease, and primary sclerosing cholangitis can be seen more commonly with ulcerative colitis, and even with the Crohn's disease. Fistula or fissuring are complication of Crohn's disease, and cancer can be seen in both Crohn's and ulcerative, with more incidence in ulcerative colitis. And Crohn's can start at any point in the gastrointestinal tract. Rectal involvement in ulcerative colitis is rectal involvement is started in or occur in 100% of cases. This is another table to differentiate features of Crohn's and ulcerative colitis. The presentation is started at the age of 15 to 35 in Crohn's, or throughout lifespan. In ulcerative colitis, the site of appearance is started from the mouth to the anus, or colon to the rectum, and colon and rectal mucosa. In ulcerative colitis, rectal mucosa started, the lesion started in the rectal mucosa. Type of the lesion: the inflammation is transmural in Crohn's disease, and superficial ulceration are common in ulcerative colitis involving the mucosa. Microscopical finding: non-caseating epithelioid granulomas are found in 50% of cases. Crypt ulcers and crypt abscess and crypt distortion are feature of ulcerative colitis. Skip lesion is a feature of Crohn's, whereas continuous involvement is a feature of ulcerative colitis. The appearance also cobblestone pattern is a feature of Crohn's, and creeping fats, ring sign on X-ray. Loss of hydration or lead pipe appearance, and friable atrophic mucosa. Clinically, the patient with Crohn's disease can present with right lower quadrant pain, fistula, and fissuring. Left lower quadrant pain in left lower quadrant pain is a clinical presentation of ulcerative colitis with evident bleeding per rectum. Transmural inflammation along the gastrointestinal tract, transmural inflammation, and destruction of the colonic mucosa and submucosa in ulcerative colitis. A term or subject called colitis associated neoplasia. Colitis associated neoplasia. That is give us a hint for the inflammation associated with increased risk of neoplasia in the future, especially the long-standing or long-term inflammation with many attacks of active inflammation. It is a common complication or in ulcerative and Crohn's disease, in which the attacks of chronic inflammation, chronic colonic inflammation, will be followed by focus of neoplastic changes or dysplastic changes. This is started as dysplasia, mild, moderate, and severe dysplasia until the mature or full-blown carcinoma, invasive cancer. The risk of development will be related to the duration of the disease. So colitis-associated neoplasia risk is increased after like 10 years and more, 15 years. And the extent of involvement, so widespread colonic involvement, pancolitis, is associated with more risk of neoplasia in the future, extent of involvement, and also the number of active attacks or active relapses. With neutrophil infiltration indicate activity always. Neutrophil presence indicate active ongoing inflammation, responsible for glandular destruction, reparative changes, and onset or presence of dysplastic changes in the epithelial cells. And thank you. I complete the small and intestinal diseases. The left part is only tumors of the small and large bowel.